Well, welcome to this episode on medical terminology, where I'm going to ensure that we all understand the medical term dyspnea and use it appropriately as healthcare professionals, right? I also believe that we have a little bit of fun learning how it has been used outside of the healthcare settings you might recognize. Hey guys, I'm Dr. Busti, and welcome to This Is Why, a show dedicated to helping healthcare professionals understand the why behind what we do and what we talk about in everyday clinical practice. So let's start with the word itself, because as always, the terminology gives us insight into the concept. Dyspnea comes from Greek, where dys, means difficult, disordered, bad. The pnea, right, it relates to breathing. So dyspnea, so at its core, simply means difficult or disordered breathing, okay? But here is where the clinical nuance begins, okay? It's very important that we follow through with this piece, because dyspnea is not just about the mechanics of breathing. It's about the experience of breathing, and that distinction matters. Now, historically, dyspnea has always been used as a descriptive symptom rather than a diagnosis. Physicians and providers would document dyspnea in patients with what we now clearly define as asthma, heart failure, pneumonia, or other cardiopulmonary conditions, right? But the term itself in the past never told you the cause. It told you what the patient was feeling, and that becomes critical in clinical reasoning, right? Because if you stop at dyspnea, you have not answered the question, you have only identified the problem, right? So the question becomes, why is this patient experiencing dyspnea? Now consider how this evolved into modern terminology, okay? We still use dyspnea in clinical documentation and teaching today, but when we speak to patients, we usually translate it into things like, right, shortness of breath or breathlessness, right? And that translation is not just about simplifying language, it reflects the fact that dyspnea is inherently, guys, subjective. It is defined by the patient's perception of breathing discomfort. And so the key concept here is to ensure that you understand that point. But furthermore, dyspnea is not the same as things like tachypnea, which is about increased rate of respirations, right? So it's not the same as hypoxemia, right, which is low oxygen levels. A patient can have, be hypoxic, right, and not feel dyspneic, right? And a patient can have and feel severe dyspnea and have a normal O2 saturation. I see that all the time. So think about it this way. Dyspnea is the symptom, okay? The others, pulse ox, respiratory rate, those are signs or measurements or objective findings. And if you do not separate those in your mind, your clinical reasoning can go off track very quickly. So now let's take it one step further. In modern clinical practice, dyspnea forces you to cross multiple systems, okay, body systems. Pulmonary causes like asthma, COPD, pneumonia, pulmonary edema, pulmonary embolism are often some of those first things that come to mind. But cardiac causes such as heart failure, ischemia are also equally important. And then you have non-cardiopulmonary causes like anemia, metabolic acidosis, or how about psychiatric things like anxiety, panic disorders. So when a patient says, I feel short of breath, the real issue is not the symptom itself. The real issue is identifying the underlying physiology driving that perceived sensation. So is it increased work of breathing? Is it impaired gas exchange? Is it a mismatch between ventilation demands and or capacity? Or is it a central perception issue like anxiety? Okay? And this is where clinicians distinguish themselves, not by recognizing dyspnea, but by explaining it. Now, let's connect this to something more familiar. Okay? Think about the movie Top Gun. All right? During those high-speed aerial maneuvers, the pilots are shown breathing forcefully, right? Almost aggressively to maintain consciousness under those high G-forces. Well, they are not saying the word dyspnea, but what you are observing is a physiologic response to an increased oxygen demand and altered hemodynamics. And in that situation, the body is working to prevent loss of consciousness. So the question becomes, is that dyspnea? And the answer is not necessarily, right? That is a controlled compensatory breathing strategy. But it also helps you to understand how the body responds when oxygen delivery and demand are challenged. Now let's contrast that to like a scene in Hunger Games where the character says, "I can't breathe." Right? Here, you are seeing a combination of exertion, stress, and possibly panic. And now we are much closer to what patients actually describe in clinical settings. They do not say dyspnea, they say, "I can't catch my breath." And that is your entry point into that clinical reasoning, because now you have to determine whether this is physiologic, pathologic, or psychogenic. All right, now consider the patient sitting in front of you. Okay, they say, "I feel short of breath." Your job is to break that down. When did it start? Was it sudden or was it gradual? Okay, is it worse with exertion or at rest? Is it positional, like orthopnea? Okay, is there associated chest pain, cough, fever, or edema? Each of those questions is not random, guys. They are actually being targeted to identify the underlying cause of the dyspnea. So for example, sudden onset of dyspnea with pleuritic chest pain should raise the concern of pulmonary embolism, PE. Gradual worsening of dyspnea with lower extremity edema suggests heart failure. Dyspnea with wheezing may point towards asthma or COPD. And dyspnea with normal exam findings but at high anxiety may suggest psychogenic component. Okay? And so this is why the term dyspnea is so powerful. It forces a structured approach to thinking. Now let's ground this in a formal definition, right? So the American Thoracic Society defines dyspnea as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. And that definition is important because it emphasizes subjectivity and variability. Another more traditional definition would describe dyspnea as a difficult or labored breathing. Both are correct, but one emphasizes the patient experience and the other emphasizes the observable concept. And as clinicians, we have to hold both perspectives at the same time. So the takeaway here is simple but important. Dyspnea is not a diagnosis. It's usually a symptom, it's subjective, and it's typically the starting point for a deeper clinical investigation. And if you understand that, you move from memorizing terms to actually thinking like a competent clinician. And that is the goal. So thank you guys so much for joining me on this episode on dyspnea. If you found this to be helpful, continue to follow us and subscribe to us and give us a like if you don't mind on thisiswhy.health and at our YouTube channel. We really appreciate that. It continues to support what we're doing. We are here to focus on understanding the why behind what we do in clinical practice because that changes the how. Take care.